Hi, my name is Francis Merrick. I'm the National Director for the American College of Sports Medicine. Today we're going to be exploring what qualified health practitioners, national provider identifiers mean for clinical exercise physiologists. Today's presenters are Dr. Paul Gallo. He's a member of the ACSM Certification Board and the chair of the Continuing Professional Education Committee. Michael Lynch, he's a member of our ACSM Certification Board and the chair of the Clinical Exercise Physiologist Committee. Robert Berry, who is on the EPCP Reimbursement Task Force, Dr. Brittany Overstreet, who is a member of our Clinical Exercise Physiology Subcommittee, and then also a member of the EPCP Reimbursement Task Force. If you have any questions, please type your questions in the chat bar, and we'll answer them at the end of the webinar. Anybody who's registered for the webinar will automatically be provided the recording of the webinar. Without further ado, the floor is yours, Bob.
Okay, sure. Can you advance the slide, please? And one more time. So none of us have any disclosures, and the objectives are we want to understand how the qualified healthcare practitioner is defined as part of a competent workforce, discuss the gap in current state regarding clinical exercise physiologist, and how you get recognized as a qualified healthcare practitioner. Discuss a little bit about how billing works both for an individual and a facility, and probably the most interesting part is what the task force is doing about this. Next slide, please. So seems an appropriate place to start off is defining a qualified healthcare practitioner, and you have the definition up in front of you that was adopted by the American Medical Association in 2013. What I think is interesting about this is where it's parenthetical. Licensure/regulation when applicable, and facility privileging when applicable. But essentially, a qualified healthcare practitioner is someone who can bill independently on the physician fee schedule. Next slide, please. So why do we want to become qualified healthcare practitioners? Well, if any of you can remember back to the crazy happy days of 2019 pre-pandemic, right around the middle of 2019, the American Medical Association released about 30 new Category 3 CTP codes that describe services that clinical exercise physiologists could potentially perform. And these are like health and wellness type coaching, patient self-management, education, and the provider that can submit these codes is either by statute a physician or a qualified healthcare practitioner. So backing up just 1 second, Category 3 CPT codes means these are new codes and they are experimental, and they're trying to figure out what the return on investment is of providing these types of services. Next slide, please. So why do we want to become qualified healthcare practitioners in the context of what I just said? It identifies the clinical exercise physiologist as an individual that physicians, employers, and the public can feel they know that they can deliver this service, so they're competent to do this specific task. It's worth noting that most clinical exercise physiologists will probably continue to work under the direction of a physician. Some may choose to work independently. Becoming a qualified healthcare practitioner allows for both options. Next slide, please. So, driving the point home, being recognized as a qualified healthcare practitioner is going to increase reimbursement opportunities. We've got 30 codes that we can't bill for right now, and it helps add value to healthcare facilities and teams. You know, why do some people in healthcare make a lot more money than other people in healthcare? Because the people that are making more money are adding more value to their facility. Physician can do pretty much everything. They're the highest paid. They're the top of the pyramid. I think we're going to hand this off to Dr. Overstreet. And next slide, please.
All right, thank you so much. Now that we have a better understanding of what a qualified healthcare provider is, I'd like to just take a few minutes to discuss how we as clinical exercise physiologists specifically fit into this and how we get there. So it's probably not a surprise to anybody on this particular webinar, what a CEP or who a CEP directly is. We are healthcare providers trained to work with individuals who have chronic diseases in regards to where exercise has shown to have therapeutic benefits. We're uniquely trained to work with individuals both acutely and in chronic states, both with disease and without disease. And a lot of times, as Bob just mentioned, this is going to happen in a medically supervised program or environment under the direction of a physician. We're trained in varying levels. Mostly, we need to have a specific degree in our practice regarding exercise physiology, exercise movement sciences, kinesiology, or something of the like. And we do have a state in the country where we are licensed, but most of the time we are going to be considered certified professionals. Next slide, please. When we look at the core job competencies of a clinical exercise physiologist, they range and we have quite a vast skill set. We do everything from patient-client assessments to clinical exercise testing, exercise prescription development, exercise training and supervision, again with these high-risk populations, education and behavior change, and then of course professional and legal responsibilities. Next slide, please. Despite the vast qualifications that we have, we are still limited in what we can practice and where we can practice, with the majority of that being in a cardiac and pulmonary rehab environment. If we look at where CEPs are right now in regards to the technical requirements of becoming a qualified healthcare provider, we have what it takes to be a QHP. If we look at the professional, the professional requirements, they include a professional registry, which is going to be discussed later on in this presentation, an accredited certification, which we have through the American College of Sports Medicine, continuing education, which is going to be shown on the next slide, and then the last is going to be the accredited education, which is in progress right now. So in regards to this, the one thing that won't be discussed later on is going to be the continuing education credits, which you can see by this slide, we have ample opportunities for within our field. These are just some of the ones that are listed on the American College of Sports Medicine's website, and this just goes to show that we have the foundation and the necessary qualifications to get where we need to be in order to qualify as a QHP. Next slide, please. So when we look at all of this, as you can see, there's check marks between the professional registry, the accredited certification, our continuing edu credits, which we just saw. And then in regards to our accredited education, if you were on our last town hall, you learned a lot about that process and the fact that we will have that established within the 2027 schedule. So by 2027, all 4 of these will have green check boxes, and we are in the progress of making that happen, which is a really exciting time because once we have these established, we can move forward with the benefits of what a QHP status is going to provide us. Next slide, please. When we look at the qualifications and where it gets us, once we have these established, we will also discuss the National Provider Identifier, which is going to be discussed in just a few slides. With all of this in mind, we qualify as that non-licensed QHP. That is one step closer to the CPT and Icd-10 codes, which will help advance our skill set and where we can practice and who we can practice with, and then, of course, hopefully become reimbursed for that. Once we get that, we can be a better part of our community and we can help definitely reach out to those individuals and those populations and those chronic disease groups that we're currently not able to serve as well as we would like to. One thing that the task force is currently doing is we're trying to promote this information. And it's an unfortunate truth that we're probably not as recognized in the healthcare field as we should be. And individuals aren't quite always sure what a clinical exercise physiologist is or what we do. And so one of the things that will be coming out later this summer is going to be a technical requirements for clinical exercise physiologist and qualified healthcare providers article. It'll be published in ACSM's Health and Fitness Journal. This is going to outline all of those core pieces to becoming a QHP that we just discussed in significantly greater detail. It's going to outline exactly what we do, who we are, and how we qualify for this. And then we'll be able to use this as a template for discussions with other healthcare providers to really stand on our own 2 feet and advance the profession forward. With that, I believe we are passing it off to Michael Lynch. Or back to Bob, I apologize, back to Bob.
That's okay. So just talking about the way services are billed for clinical exercise physiologists that are working in hospitals. And we're going to focus specifically on cardiac rehab, pulmonary rehab, and stress testing because the most recent CEPA salary survey says that about 71% of all the clinical exercise physiologists that responded work in one of those three areas. And what's notable about those areas is that the CPT codes, common procedural technology codes that are used in those areas are not associated with a particular discipline. So you don't have to be a CEP, a physical therapist, an RN. Okay, anybody can submit the code because it's being billed by the facility, not an individual. At this time, and this is what we're working to change, there are no CPT codes that are appropriate for an individual clinical exercise physiologist to use. Now we're going to pass it off to Michael.
Yes, hello. So billing as an individual provider is quite a different experience than billing under a group. And what we're talking about essentially is creating the back-end structures, and so that a CEP at one point, whether it be in a hospital facility or their own private practice or clinic or gym, could have the potential to bill as an individual provider. There are many steps on the back-end process that would require. Later in today's presentation, I'm going to speak a little bit further in depth to what that entails. I'll speak to that experience as someone who is also a registered dietitian. I'm in private practice and have been billing as an independent provider on my own as a dietitian for a couple of years now. And so I'll speak further to that. But at this point, as Bob has stated, or Robert, excuse me, there is no established CPT codes that would allow a CEP to bill or be reimbursed. And so we'll speak more further to that process a little bit later in the presentation. So at this point, I think we'll pass it back to Paul.
Great, thank you, Michael, and welcome everybody to today's webinar. It's a pleasure to be here with you this afternoon Eastern Time to share this information. Next slide, please. So what I'm going to do is provide an overview of available resources to identify clinical exercise physiologists and qualified health fitness professionals. The first resource I'm going to share with you is the National Provider Number, or NPI, which I'll be spending the majority of my content and time on. The second resource I will mention is the United States Registry of Exercise Professionals, also referred to as US Reps. Next slide, please. So what is the National Provider Identification, or NPI? Well, it's a unique identification number available to recognized healthcare providers. And anybody that's worked a day as a CEP knows that we are in fact healthcare professionals and healthcare providers. The NPI is used by healthcare agencies, health insurance companies, or other healthcare providers to identify the QHP who is rendering those services. I'd also like to add that the NPI is also a simplified method to identifying CEPs, where they work, how many of them are in an organization or facility, and the associated services of the CEPs. Next slide. The attributes of the NPI are quite simple. The NPI is a 10-digit identification number that remains exactly the same regardless of the taxonomy code one uses, name or address changes, or even if you change employers. This NPI stays with you the duration of your professional career. A taxonomy code is an assigned numeric code to represent a professional classification or area of specialization. Only one NPI is assigned per person per taxonomy. For example, I am both a certified and licensed athletic trainer and a certified clinical exercise physiologist. I'm one person, I have one NPI, and that NPI is assigned to one of my taxonomy codes, which means I have to pick athletic trainer or clinical exercise physiologist. The NPI only provides an individual's name, place of employment, and the services associated with their assigned taxonomy code. No other personal information can be retrieved once an NPI is registered to an individual. The other really nice thing is that NPI application is free for any professional wishing to apply for one. The National Plan and Provider Enumeration System, or NPPES, is responsible for managing the NPI registry. The NPPES was created by the Centers for Medicare and Medicaid Services, which I will refer to as the CMS this point forward. Next slide. So who should have an NPI? Well, again, any healthcare provider who uses electronically transmitted health information associated with the Health Insurance Portability and Accountability Act, or HIPAA. HIPAA has 6 standard transactions identified, as you see in the table before you. For any individual who would like more information or definition on these 6 transactions, please visit the CMS website and download their fact sheet that nicely defines what each of these transactions are. In general, a healthcare transaction is an exchange of information between 2 parties to carry out financial or administrative activities associated with those services rendered. Next slide. The NPI itself has 2 levels associated with it, which does cause quite a bit of confusion for many individuals. Level 1 is the individual QHP. These are the healthcare providers who are sole proprietors or QHPs whom are incorporated and rendering services from their personal business. A level 1 NPI is also extremely important to help advance our profession, which I'll discuss on the next slide. A level 2 NPI is organizational or group level, and these are healthcare providers who are listed as organizations, including but not limited to physicians groups, hospitals, nursing homes. Also, subparts can be listed as a level 2 NPI. For example, a subpart could be a unit within a hospital, such as cardiac rehab, that bills for services, but is not its own entity and is part of the hospital or larger organization. Having a group NPI is not the same as having an individual NPI. So many clinical exercise physiologists may already have a level 2 NPI assigned to them if you're working in a hospital or rehabilitative setting. I strongly encourage you check with your employer to see if you're part of these group NPIs. That's not good enough though. CEPs should also have an individual NPI for some of the benefits and advancements of our profession, as I'll mention on an upcoming slide. And again, CEPs can have both a level 1 and affiliation with a level 2 NPI. Next slide, please. So why is it important to have an individual NPI? Well, the benefits, as explained by the CMS, include simplification of electronic transmission and improved coordination of communication between healthcare providers as well as healthcare facilities. The NPI also provides a standardized health identifier for QHPs in a single location. Why is that important? Individual NPIs tell us how many CEPs are working, where they are located, and what services they are associated with. Now, I want to be very clear. An individual or level 1 NPI does not allow the CEP to bill for services. My colleague Bob mentioned this earlier in the webinar. That is usually done through the facility or organization. So how can the NPI advance our profession? Well, the NPI itself can be a quantifiable measure of our practicing CEPs. This will increase our national presence of the profession and is a count to do so. It also increases recognition that will help advance legislation for CEP reimbursement and licensure, which is currently underway. There are currently, and according to the Department of Labor statistics, 18,000 working CEPs. Unfortunately, only about 22% of these individuals have a level 1 NPI, which is about 4,000 of the 18,000. So in addition to this being an informative webinar, it is also a call to action. If you do not have your level 1 NPI, get it today if you can. Next slide. So how can a CEP apply for an NPI? It's quite simple and easy. Please visit the NPPES website as listed here on this slide. You will need to create an account and complete the NPI application process, which just takes a few minutes. You will need a social security number to verify your identity. However, that's a social security number, and any of your personal information will again not be made available to the public through the NPI listing. You need to enter our taxonomy code for CEPs, which is listed here in red. And yes, those are 5 zeros that you're reading there. The taxonomy classification for CEPs is respiratory, developmental, rehabilitative, and restorative service providers. That's what we're listed under. Also, reference number 6 is a recently published certification column in the ACSM's Health and Fitness Journal. This publication came out earlier this month, and is also free access and provides detailed information and all the steps you need to get your NPI today. So please visit the ACSM's Health and Fitness Journal website following this webinar. Next slide. I would now like to turn it back over to Michael Lynch.
Thank you, Paul. That was wonderful. And so what I wanted to do here with this segment of today's presentation was basically put this into perspective from a reference point of, as a dietitian, what they are able to do from a profession. And again, speaking a little bit personally from the experience of being a dietitian, as well as, again, being in private practice, primarily as a dietitian for a few years now. And so have walked through the steps of many of the back-end logistics, paneling, registration processes. So I'm hoping to bring that to the group and pull this together as far as maybe a little bit of a real-world application of all of this, again, from the perspective of an RD, and then bring it back to, from a field and from an individual perspective as CEPs, what we need to do to one day be able to do the same. And I know, speaking personally, that's just a personal dream and vision that one day CEPs can bill either as part of a group or individually. And again, whether that is at a hospital or starting their own private practices, focusing in clinical exercise physiology. So we speak a little bit about taxonomy. And so, excuse me, I wanted to provide what the taxonomy actually is for a dietitian. Now, there's kind of a lot here to take in. Primarily, it's basically the definition or the classification of what a registered dietitian would be able to do. One thing that is distinct notice is down in the red where it's highlighted is basically what they're able to perform is nutrition assessment, reassessment, nutrition intervention, and nutrition counseling. Now, that's not only what they do, but basically that's going to transcribe from a CPT code, and we're going to take a look at that here in a second of what that means. And I want to make it clear, when you're thinking about codes, whether it be CPT codes or Icd-10 codes, you can think of it like coding a computer in some regards. You're basically using a series of information as you go through these electronic medical systems to basically communicate what it is that you're doing. So there's definitions of what it is that we do, but these codes are very important. And when we don't have these codes, we can't transmit that information. So let's take a real world application look at what this would be from the perspective of an RD. So next slide, please. Next. So again, to make sure that we're all on the same page of what a CPT code is, it's basically meant to be the medical terminology or diagnostic procedures and services to entities such as physicians, health insurance companies, and accredited or accreditation organizations. Again, it's basically, it's communication is what it is. And so next, please. So if we look at, again, from the standpoint of established CPT codes from a dietitian perspective, and again, we'll bring it back to the CEP here. A dietitian has more codes than this, but these are the two primary ones that would use. The medical nutrition therapy, initial assessment and intervention for an individual, 15 minutes. Again, I bring you back to the taxonomy definition, which is basically stating that a dietitian is able to do that. So this CPT code was essentially created within the working definition from the taxonomy standpoint of this is what a dietitian is capable and able to do. And again, to be clear, we do not have those codes for the CEP. If we look at then continuing care as a dietitian, which you often do, you see people repeatedly, then you would use CPT code 97803, which is where you reassess and do another intervention. And basically it's established counseling that can go for a series of 2, 3, 10, 20 sessions. And a lot of that is based upon their insurance coverage. So one thing to note is the 15 minutes. So when you're looking at using these CPT codes, basically all CPT codes are used for 15-minute segments. If any of you have been to a doctor and wondering why they're seeing you for 10 or 15 minutes and trying to get out of there, it's because essentially you're billing for 10 to 15 minutes. That's usually what it looks like for one usage of these codes. So let's take another application. So next, please. So as you're probably familiar with, there are the Icd codes, or what's most recently the Icd-10 codes, the most recent updated versions. So there are many, many, many codes. If any of you have seen the book, it's a very thick book of just code after code after code. So to use a few examples here, again, of the classifications of the diagnostic disease in which you are assisting with, the common ones, just to pull a few out of a hat here, are E66 for overweight and obesity, E11 for type 2 diabetes, and I10 for essential hypertension. Again, as a dietitian, I use these all the time. Many dietitians do. And of course, as CEPs, we probably use many of these Icd-10 codes as well. And but again, there are many, many others out there. So we can go next here. I'd like to just show an example of what this would look like from a billing perspective. So when you are billing, there you go, thank you. So for initial assessment, what you would be doing is you would be putting into your electronic medical record the CPT code of 97802 for the assessment. And then next to that, you would be putting the diagnosis codes. And again, in this situation, being that many people have more than one comorbidity, in this situation, we're saying we saw them for overweight, or let's say obesity, type 2 diabetes, and essential hypertension. Again, not uncommon. This would be, each CPT code would be for a 15-minute segment. So if you see them for a half an hour, you would put in 2. In dietetics counseling, it's often the case that you see them for an hour. And so using 4 units is the way that you would transcribe that. What that does is that goes to essentially what's called the CMS 1500 health insurance claim form. And that form is what gets submitted to a clearinghouse, which then gets submitted to the insurance companies for review. Next, please. So if you're to do follow-up counseling, again, you would primarily use the same thing, except now you'd use the different CPT code to continue for reassessment and intervention. And again, that could go for several sessions with people, but if you see them for an hour, you would put in 4 units. And if you put in 1 unit, they will pay you for 1 unit. If you put in 4, then they will pay you for 4. As a business owner, I've become very keen to that. And essentially, the way that it works is the insurance companies have a contract with you to pay you so much money per unit. Next. And so, as I briefly mentioned, in the back end side of things, this is where it does get a little confusing, but essentially the forms are submitted to a clearinghouse through your electronic medical record, which I'm sure everyone here is familiar with using in EMR through your hospital system, or how you may chart, and then it'll be reviewed by the insurance companies. Next. So what I wanted to do is put it together and use a little bit of a comparison between where the RD profession is at and where the CEP profession is at. So next, please. And next. So if we walk through the process, again, if we start from the back end and we look from the things that we've been talking about today, Robert talked to us about the need as a qualified healthcare practitioner or professional. And that is vitally important. Dr. Overstreet spoke to that as well. We as a profession need to be recognized as a qualified healthcare provider. That is a vital step to this process, and that is in part what this task force is working towards. The next component to that is, as Paul talked to us about, which was great, the NPI, and he's exactly right. Getting an individual NPI helps to recognize that there are CEPs registered as individual providers. So as a dietitian, I have my NPI, and yes, that is it, and I feel comfortable sharing that because, as Paul told us, no private information is available via that. I can tell you from personal experience, it's basically like your social security number. When you call insurance companies, when you're looking to panel, when you're looking to follow up on a claim, the first thing that they want to know is, what is your NPI? They want to know that more than basically almost anything, because they know all of your information that they need from you is in that NPI. So as you become more accustomed to using it, it's like a phone number. You'll have it memorized and you'll use it often, often, often. From there, yes, there is state licenses that are important. And I want to be clear here, that's not our first step. I know there have been approaches at Licensure, and that was a focus for a long time. But what we need to do is more focus on the qualified healthcare provider status, all CEPs getting their NPI individually as we can, and then from there, once those are established, would be the move towards getting state licensure approval, which would be important because you have to be registered through your local health, your state health department, which is part of this. From that standpoint, you would go through credentialing. And in credentialing, what you have to do is you have to both credential with not only the insurances, but there are many health insurance companies that do this specifically. So a couple examples are CAQH and One Healthport. So you provide all of your information from there, and the health insurances will basically validate you through those credentialing provider sources. And that is a bit of a task to do. They require frequent updates, but it's part of what you would need to be able to do, or CEPs would need to be able to bill at one point. Then from there, you would panel with the individual insurance companies, not just Medicare, which I am a Medicare provider, and that's quite a process, but then you would also register for each individual insurance companies. I know they may vary by territory. Here, I'm in Seattle, Washington, looking at Blue Cross Blue Shield, Regents, Aetna, to name a few, are primary ones that I use, but essentially each individual insurance company, you have to go through a paneling process to be individually approved, again, as an individual, and then they will go back and verify you through the credentialing companies and your NPI. There's many cross checkpoints involved in this process. Then from there, once we have hopefully the established CPT codes for CEPs, is essentially where we do just going through that billing example. We'd be able to use those designated CPT codes for assessments and reassessments as we continue to work with people through exercise counseling. Again, then we'd use Icd-10 codes to communicate what it is that we're seeing them for. From there, there would be the submission of claims through your clearinghouse to the insurance company, assuming you've gone through all the correct steps. Then at that point, you would be reimbursed for those services. So it's quite a process. If we can go to the next, please. For purposes of comparison, I just want to show where we're at from the CEP profession. You can see essentially there are not many structures that we have in place at this point, which is exactly what this task force is working towards. Again, I will say from the standpoint of the need to be recognized as a QHP, we have to get that to begin, and then the process can go from there. I will say once again, the NPI is super important. So for those of you on this, or for those of you who know other practicing CEPs, I would encourage communication, start a rally kind of thing. Every CEP, you know, try to encourage them to get their NPI. It is not a hard process. It's very simple. But right now as a profession, we are essentially recognized as 4,000 of us, and 18,000 would be much stronger. And then from there, the rest of the process can proceed. But I hope that this visual creates quite the discrepancy of where we're at and what it is from a profession and from a task force that we need to accomplish. So that's what I have for you, and I'm going to take it back to Paul.
Great, thank you so much, Michael. That was excellent. So one of the other resources I mentioned at the start of my presentation was the U.S. Registry of Exercise Professionals, or US Reps. And Dr. Overstreet mentioned in her portion of the webinar that a registry is necessary in order to become a QHP. So this is a necessary step. The US Reps' purpose is to provide verification of qualified exercise professionals to employers and consumers. US Reps provides transparency on the role and importance of exercise professionals for healthcare, and US Reps also supports advancement of bills and policy regarding physical activity and the discipline of clinical exercise physiology. All professionals listed in this registry will have an NCCA accredited certification status, and that is the National Commission for Certifying Agencies. They will have a level of competency assigned, which is defined typically by their NCCA certification, and they'll have their name and location of practice listed. US Reps is managed by the Coalition for the Registration of Exercise Professionals, CREP, and they are a multi-organizational and internationally recognized registry of close to 185,000 members. In addition to the American College of Sports Medicine, other organizations that are a part of this registry include the American Council on Exercise, or ACE, National Council on Strength and Fitness, the National Strength and Conditioning Association, and the Collegiate Strength and Conditioning Coaches Association. There is a website available for US reps in our bibliography page as well. Next. Next slide. Okay, we can go next. Thank you. And that concludes our webinar. We would now like to open it for question and answer. Thank you again all for being here this afternoon.
Okay, so we have about 4 or 5 questions in the chat bar. I'm going to go ahead and go through those one at a time. So we're going to start with the first one. This is from Matt Thompson. Could you please outline any intended or unintended but foreseen consequences to clinical exercise physiologists becoming QHPs? For example, changes this would have on cardiac rehab billing, reimbursement, and operations, fee scheduling for other QHPs.
I think I'm the one that works in cardiac rehab the most intimately. So this is Robert. For that type of service, I don't anticipate any change. We would not be billing as an individual provider. The facility would continue to bill for that service.
And then the next question for the group is licensure necessary to be a QHP in billing under a CPT code? So I'm going to ask that to Bob.
Thanks. So if you think back to the AMA definition that was the first content slide of this presentation, I said what was interesting about the definition that they had accepted was that the parenthetical part where if it's required. So licensure registration if required, privileges if required. So it's going to depend on how these services are kind of contracted. You know, so if you're contracted that you have to have a license to provide a particular service, the most obvious example I can think of off the top of my head is you have to be licensed to write a prescription. So nobody other than a physician can write a prescription because it's outside their scope of practice. So I couldn't receive reimbursement for doing something that's outside of my scope.
And I think too, in order for us as a field, us as clinical exercise physiologists to qualify for those technical standards that we discussed in regards to the QHP, we do not have to be licensed. So we are actually seeking the non-licensed QHP path for the profession at this time.
Okay, the next question, oh gosh, there's a flurry coming in. The next question is, what is the justification for only doing this for clinical exercise physiologists? Why not exercise physiologists? I'll ask that to the group.
Well, I think that the clinical exercise physiologist already being part of the hospital-based care team, reimbursement's more approachable for that group at this time. This whole process is going to be a series of small steps. So start with the step that's most approachable and gain ground and move from there.
Okay, so next question is related to, I got to brush up on my acronyms here. Can you discuss the National Board Health Wellness Coaches, Health Coach CPT codes, and how and why they are further along in the process than clinical exercise physiologists?
My response to that is I think they had the appropriate focus of their process and basically just started a little sooner than what we have done here with this task force. And so I would not say that it's necessarily any better or stronger. I think they're just a little ahead of where we're at, but we're essentially going in the same direction.
I think this is Francis as the director of certification. I think one of the things for our certification board is getting alignment between accredited education certifications and how those are directly tied into a competent workforce. And Bob, I'm sure you can talk about this, is that from a programmatic accreditation standpoint, every university was preparing clinical exercise physiologists differently, which then would cause issues defining, well, how do you have the qualified healthcare practitioner or professionals, how do they know and prepare adequately for the workforce? While every university is doing that differently, it was a challenge for our certification board to answer that. Michael and Paul, who's on our board, can certainly answer those questions too. But I think ultimately being able to have a strong workforce prepared, they're going directly into the workforce, and then having the certification system as well. What are your thoughts there for Michael and Paul from our board perspective?
I would 100% agree, and I think we've observed and we've seen that from a certification standpoint. I think we feel confident in the quality of care and the capability of exercise physiologists, clinical exercise physiologists. I think where it is that we recognize that as a field and certification opportunity, we lose a lot of opportunity because of the either inability or difficulty of making a career out of it, and thus taking these steps to facilitate those who have gone through the certification process to also be able to apply it in a way that would be more equivalent to other healthcare providers, such as dietitians and physical therapists.
Yeah, and I would agree as well with what Michael and Francis said. I think the accreditation status is important for standardizing the programmatic education associated that builds into the certification, and again, will just let us be better at what we do, as well as getting us closer to that QHP status and part of the care team alongside physical therapists, registered dietitians, etc. Which really, that's where the CEP is already working. We're kind of on that forefront. We just need the recognition for it.
Question from a student for you all. Is there a deadline when it comes to applying for an NPI?
No, so an NPI, I don't believe there's any deadline associated. We encourage you to get it as soon as you can. One of the other things I'm hoping with the accreditation of programming and the education is that this becomes part of the educational process. How great would it be for our programs to include NPI registration just immediately after an individual completes their degree and gets their diploma? So that is something I think if you are eligible for it, getting it sooner is better.
One question is, just to clarify, NPI does not provide any sort of protection for the individual, but in our case, for clinical exercise physiologists or exercise physiologists, provides a mean of tracking where individuals work. Is that correct? And I think that goes to potentially Bob on that one.
Paul actually looked like he was chomping at the bit to answer that question.
Paul, it is.
Okay, yeah, from my understanding, the NPI does not provide any sort of liability coverage, if I'm understanding that question correctly. And in addition to the benefits of communication and seamless transaction from healthcare facilities and professionals to one another, like Michael mentioned, it becomes almost like your phone number or your professional social security. That's really the benefit of it. An added bonus is tracking and giving us a quantifiable number of our workforce, saying, hey, we are relevant, we are here, look how many of us there are. And that helps tremendously with the reimbursement and QHP argument and making a case for CEP.
I would completely agree with that. In recalling the question, I'm not sure if I heard possible concerns of getting the NPI, but there really is no concern, because as a provider, whether you're a provider from the standpoint of a qualified healthcare provider, professional, or you're a CEP or a personal trainer for that matter, you're still basically liable or responsible for the quality of care that you provide. So there's absolutely no risk of having an NPI and how that creates any further risk for you as a provider.
Yeah, Michael, I think that's a great point. It all boils down to your professional competencies associated with your level of certification, level of education. Whether you have an NPI or not, you are still liable if you act negligently.
Next questions from students. What advice do you have for students finishing a degree in a exercise science or clinical exercise physiology program wanting to enter the profession?
Francis, can you repeat that question? I'm sorry.
For students who are entering the profession, what advice do you have for them?
Well, my advice would be take advantage as you start your academic trajectory. That's where your career starts, as while you're studying. Take advantage of internships, getting into hospital settings with people like Bob, people like Michael, learning and just kind of getting as much experience under your belt as possible. Remember, a certification is entry-level competency. What are you doing in addition to that to hone your skills, find the areas that you're most interested in? That's extremely important. So again, taking advantage of internships, getting an entry-level certification that's NCCA accredited, and then really just becoming involved and networking within the profession, getting your NPI, staying up to speed with current literature, continuing education that's cutting edge, and making sure you're growing with every opportunity.
I'm going to second what Paul just said regarding getting involved and making sure that you're staying up to date with the latest that's coming out from national organizations such as ACSM, CEPA, AACVPR. This is where you're really going to be able to make sure that you're staying at the forefront of the field and helping us progress the field and making new ways and being able to really help on these efforts instead of just keeping us kind of in our silo that we've been in for the current time. So definitely make sure that you're staying on top of that and getting involved as much as possible.
And one thing that I'd like to add too is maintaining your optimism. And what I mean by that is I feel strongly about where it is that we're going from a task force and where the future of the CEP and the EP and exercise fitness training is essentially going. What I will say too, from the opportunity of whether you say billing, which is what we're working towards, but I see a lot more preventative wellness, and I think CEPs and exercise physiologists are perfectly well suited for that. And where I reference the billing is, again, as a dietitian, I'm seeing more and more insurance companies being open to preventative care. So it used to be you would have to be, say, obese to be qualified for nutrition counseling. And now I see if they're non-obese and I still submit a claim, it will fall under preventative and it's being more and more covered. And I think that's being well recognized in the field. And I think us as clinical exercise physiologists and fitness professionals are going to be well suited to be in that space of preventative wellness, whether that be directly billing or in other facilities that you may work in or possibly your own. So I think there's a lot of great opportunity coming.
Okay, we all seem to have really strong opinions on this, so I'm going to just reiterate what Paul said about the importance of getting a certification. As an employer, when I see resumes come across my desk for clinical positions, the people who have a clinical exercise physiology certification from ACSM, in my mind, I've already set them apart as being, they've gone to the trouble of taking time to learn what the expectation is in the field. Okay, and that is, again, using Paul's words, it's evidence of minimal competency. If you've heard horror stories about maybe people that took the ACSM exams in the 90s and the early 2000s, it's really been right-sized. And what we're looking for is not the aspirational candidate where if this person passes his test, you should hire him on the spot. Okay, we're looking to make sure this is somebody that, they understand the basics, they know what they need to know, and get them, demonstrate that by passing the exam. That's going to put you a big step up on your career path.
All right, so this is a very complex question, and so be ready to answer this one. Which step in order of treatment would a clinical exercise physiologist, clinical exercise physiologists fall into if recognized as a QHP? For example, let's say a patient gets diagnosed by a physician, then treated by a physical therapist, then treated by a clinical exercise physiologist. So when we're talking about the CEP and the QHP, how would we approach that?
So I think if they're diagnosed by a physician and they have an acute musculoskeletal injury, which is kind of the scope of practice that PT is going to address most often, once they get through that acute injury phase, there's very, very few maintenance style, what cardiac rehab would refer to as phase 3 physical therapy programs. The volume of patients that they treat is just too high. So when I was involved in the licensure effort in Massachusetts, one of the ways we got a co-sponsor for the bill was a woman that worked in the legislator's office had a husband who had a stroke and had residual deficit. So he gone to physical therapy, maxed out his rehab potential. He was discharged appropriately, but he still can't just go to Planet Fitness. He needs someone who has the clinical skills, know-how. And that's kind of what got that person on board. And that's how I see this. We would be additive care where appropriate.
Yeah, Bob, I really like that explanation. And I think, as I mentioned earlier, we're on the forefront, again, just wanting the recognition as a QHP. And as an athletic trainer who worked in outpatient physical therapy, both full-time and per diem before getting into higher ed, that was something we would see too, is where was the maintenance programming when these individuals were done rehabbing the shoulder? And this is where a lot of the clinical exercise physiologists, step one, and I do believe the exercise physiology or EPC professionals can also play a role here eventually as we continue to move down this path. It is the holistic side of it. So we're talking a lot of preventative codes and preventative medicine, but there's the post-rehabilitation side of it as well, where education, behavior modification, and expertises that the CEP has will be so critically important. So I do appreciate your response there, Bob, and agree fully with what you said.
I think too, it's an exciting time to start thinking about what this could mean for the future. Thinking about being able to carve your own business or your own path or your own practice into this, and creating new ways for the CEP, things that aren't necessarily in the system right now. So, to Michael's point of being optimistic and being excited and keeping that enthusiasm there, this is a great step for our field as a whole, and it is an exciting time to be part of it. So this is something that we'll be able to really make a big difference in the future.
And I absolutely, with all that's been said, and I think looking at to Bob, what Bob from the old days, Robert today, is looking at where from a physical therapy standpoint, where they go from essentially dysfunctional to functional, but we take them beyond that. And I see that as being hopefully an established at one point relay system, is once they have that functionality, we as CEPs or EPCs can take that further. I think, of course, also looking at diagnoses of diabetes and things of that nature, that would be a direct route to the EPC and PC from a physician establishing a diagnosis of diabetes, and the exercise physiologist is a direct referral, looking at those opportunities as well.
And to be absolutely 100% clear, I don't see the clinical exercise physiologist or perhaps the EPC at one point necessarily being subservient to the physical therapist. Michael just made me, that you have to go through the physical therapy route, and then once to Michael's example, if I had someone who had a total knee replacement, that's a classic PT referral, right? But they're also morbidly obese and have type 2 diabetes. The PT is not going to really address the type 2 diabetes, okay? But we could co-treat. And in my career, I've often done that, mostly in the inpatient setting, but co-treating is definitely probably going to be more the norm than not.
So there's a comment in the next one. I'm going to go to the next question because we're running about 5 minutes to the top of the hour. One comment is, please don't call it maintenance, it's progressive to reach optimal endpoints, is a comment to this section. The other one is, how long do you think it will take clinical exercise physiologists or exercise physiologists to become qualified health practitioners? What can we do to help move to QHP sooner?
I don't know that there's a definitive timeline I would feel comfortable stating for a QHP that would necessarily make any sense. I think, again, to reiterate, the NPI individual would facilitate us in that process. So as far as what it is that you can do, I think from the standpoint of the task force, I think we're always looking for people who are ready to assist in that process. And I know there's been a lot of interest. If you don't mind, Francis, me bouncing it back to you from a task force perspective, do you have any perspective on that?
I think at a minimum, you have to wait till 2027. I think when you're talking about, when you're looking at the 4 components of most professionals, we have standardized education, we have the certification which we already have, continuing competency standards which we already have, and then a registry. The registration being US reps already there. The one piece that we're waiting on before we really kind of start pushing for it is the standardized education, both for exercise physiologists and clinical exercise physiologists. Without that, I think you're you're going to run into a very, very quick cliff where they're like, where is the standardized education? And then off. I think, Bob, I think the discussions that you've been actively involved with in the past, I think ran into that. What were your thoughts there?
Yeah, that's the absolute must-have piece of this puzzle. So I was glad to hear you say that 2027 is really the starting point, because that's when candidates for the ACSM exam are going to have to come from an accredited program. What Francis was referring to in terms of other discussions I've had, in 2012, I was way deep in the licensure effort for Massachusetts and testified at the State House in Boston. And I testified against a representative from the American Physical Therapy Association. And I want to be clear that individual physical therapists all seem to understand the difference between what they do and what we do. The APTA is very active in protecting their membership. So they tend to follow any legislative efforts along this line. In the comment that was made, we had as a scope of practice, when you have a license, you have to define what you are licensing. What is the scope of practice? And we had included all of the domains from the Registered Clinical Exercise Physiology exam when that credential was available, because we did not want to pigeonhole clinical exercise physiologist in cardiac pulmonary rehab and diabetes education. We wanted room to grow the profession. So we included neuromuscular, orthopedic, immunologic, and we got pushed back hard on the musculoskeletal and neuromuscular. And the comment was, yeah, you studied this and you know this because you took the RCEP exam, but not everybody else did. And there's no way for us to separate that out. So until people come from a standardized academic program, we're going to continue to run into that. Think about registered nurses. Registered nurses have great portability. They can go anywhere in the country and get a job. Why is that? Their preparation is very, very, very similar. Everyone knows if you went to nursing school, you have a nursing license, you've studied these subjects, you passed these exams, and that's the point that we have to get to if we want to be considered as equals.
I agree. And I actually had that exact same experience here in Delaware when we were considering licensure as well. So it's definitely not limited to just one state. That's across the board a big issue. And I think to that point, something else that we can continue to do in the meantime as we look forward to 2027 is really work on increasing awareness of our profession, being able to take things like the technical paper, the technical report that's coming out later this year, and being able to go to other professionals and say, here it is. This is who we are, this is what we do, and this is how we're qualified. That way they have a better understanding of what resources we can provide to patients and clients in the future. And that way, you know, it's just a little bit less of a hill to climb when we're ready to really go for it.
I think that the rest of the questions, there are some great questions are coming through. I will stop it there, but I guess to the panelists, do you have any kind of closing thoughts while we kind of wind down this webinar?
My closing thoughts are, if you're not currently ACSM certified, you should get so as soon as you possibly can. If you're not currently involved with the Clinical Exercise Physiology Association, you should. They're the organization that's looking after the professional interest of the CEP in conjunction with ACSM. We are an affiliate society. We work together, but many hands make light work, guys.
And with regard to my component of the webinar, if you do not have an NPI and you meet the qualifications, get yours today. The ACSM's QHP task force and the CEPA both do support this and encourage it of their members for the ACSM and CEPA as well. It's been an absolute pleasure sharing this information with all of you today.
All right, thank you so much. We will be doing our next webinar or town hall soon. I think there is a really great one that came in as a recommendation, is to focus on scope of practice. So I think we've kind of discussed that as a group in the past, and so I think maybe we could be something on our next town hall. Thank you all for joining. As a gentle reminder, anybody who's registered for this event will get the recording. And then there's going to be a follow-up blog post that answers all of your questions that we didn't answer. And then the slides will be available there. Thank you so much for joining us today. Take care.
Thank you.
Thank you all.